respected chairperson, co-speakers, and my dear friends, and heartfelt thanks to Dr. G. Vijayakumar sir. And I'm going to talk on recent advances in management of diabetic kidney disease. We all know diabetes is a chronic metabolic disease where hyperglycemia leads to various acute and chronic complications, chronic being micro and macrovascular complications, and diabetic kidney disease is one of the major complications of diabetes. And diabetic kidney disease affects 20 to 40% of adults with diabetes, and it is a leading cause of kidney failure globally. And at least 40% of patients with type 2 diabetes have a chronic kidney disease. And out of that 40%, 50% progress to end-stage renal disease. And we have to understand that 10 times there's higher prevalence of kidney failure in patients with diabetes compared to those who don't have diabetes. Now, how is that we detect diabetic kidney disease? Those were the days where we are looking at urea, creatinine, and we were looking at oliguria, we are looking at hypertension, we are looking at pedal edema. So these are the stages of end-stage renal disease where nothing much could be done for most of our patients. So nowadays, most of our screening guidelines are based on eGFR and urine albumin creatinine ratio, where for in type 2 diabetes, it has to be done at diagnosis. In type 1, it has to be done 5 years after diagnosis or 16 years of age, whichever is earlier. And of course, depending on the staging of the chronic kidney disease based on your eGFR and urinary albumin creatinine ratio, you monitor them every 1 to 4 years depending on the stage of the disease. And your target would be to reduce your urine albumin creatinine ratio by more than 30% from baseline if it is more than 300 milligram. In spite of clear-cut screening guidelines, the current challenges is that there's a very late detection in 30 to 40% of the cases. I'm sure even in most of our clinical practice, we very rarely do eGFR or we very rarely do urine albumin creatinine ratio. We are still going by urea creatinine because once when your creatinine or urea starts rising, your eGFR has declined to less than 25 to 30%. So which means nothing much could be done for our patients. So we have really missed the golden opportunity of preventing your kidney progression of kidney disease. And in spite of, and we are sure most of patients for prevention, we have been using a RAS blockade, we have been using AC inhibitors or ARB, but still if there's a residual albuminuria, we don't really hike up the dose. And there's a high CV risk despite treatment because most of our CKD patients are diabetic kidney disease patients. They die because of a cardiovascular event. Very rarely they die because of a end-stage renal disease. Many times they die because of a cardiovascular disease. So based on these things, I'll tell you because most of the guidelines, they still say we have to really risk stratify most of our patients based on your eGFR and based on your urine albumin creatinine ratio. I'll tell you why is it very important for us to do both these things for our patients. Here you see a gentleman with the eGFR of 62 ml per minute, and when you try to plot him with the grade of eGFR, so he falls into a low risk category. For the same gentleman, you do a urine albumin creatinine ratio also. Now his urine albumin creatinine ratio is 350 milligram per gram. Now when you stratify, he becomes in the high risk category. So just looking at only eGFR or adding urine albumin creatinine ratio totally changes the risk category of the patient, which means this patient has to be very stringently controlled for his blood sugar, and we have to prevent his progression of kidney disease. So guidelines very clearly recommend using both eGFR and urine albumin creatinine ratio to properly identify, stage and monitor CKD in patients with type 2 diabetes, as eGFR alone may miss early stages of CKD. Now, why is this diabetic kidney disease happens? It is very important for us to understand the pathogenesis because then only we will know how each drug acts on our patients with diabetic kidney disease in preventing the progression. So the key driver of diabetic kidney disease is hyperglycemia, where chronic hyperglycemia leads to advanced glycation formation, and you have intraglomerular hypertension, which increases glomerular pressure, which in turn decreases GFR. You have RAS activation in terms of angiotensin II. You can have vasoconstriction fibrosis. You can have inflammation where cytokine release and immune activation happens. Ultimately, all these pathogenic drivers, they cause structural changes in the nephrons, especially basement membrane thickening, podocyte loss, mesangial expansion, and ultimately it leads to tubulointerstitial fibrosis. So this tubulointerstitial fibrosis and albuminuria are very closely related, and both are highly prognostic biomarkers of kidney failure. So when you look at a patient, you can see your albuminuria, which is just increasing, and you can see the EGFR. Your albuminuria most closely correlates with your kidney fibrosis. Even in patients with urine albumin creatinine ratio as low as 30 milligram per gram, there is association of increased all-cause mortality and cardiovascular mortality in patients with chronic kidney disease. Now, how do you prevent this chronic kidney disease, or how do you prevent the progression of chronic kidney disease? Controlling glycemia is very, very important. Currently, RAS inhibitors, all of us are aware, so which I will not go into detail of RAS inhibitors, so which is the essential first line therapy. You can use ARB or ACE. So it controls the blood pressure and it reduces the proteinuria to protect the glomerular artery structure. We have SGLT2 inhibitors where you have proven kidney and cardiovascular protection. They reduce hyperfiltration and lower the CKD progression. And we have non-steroidal mineralocorticoid receptor antagonists which further reduce proteinuria and deliver meaningful cardiorenal benefits beyond RAS blockade. And now we have GLP-1 receptor agonists, which is again jumping into this market, where there's increasingly adopted for cardiorenal protection with the emerging landmark trial evidence of diabetic kidney disease. So I will take up SGLT2 inhibitors. So the mechanism of action of SGLT2 inhibitors, how it exactly is helpful in diabetic kidney disease is that it has a tubuloglomerular feedback mechanism where it helps to restore the intraglomerular pressure. It has an anti-inflammatory mechanism where it decreases inflammation and it reduces oxidative stress. It causes natriuresis where it promotes sodium excretion and reduces the volume overload. It has metabolic effects by improving the insulin sensitivity and decreasing the glucose toxicity. So we can use SGLT2 if your initiation crave when your EGFR is more than 20, some say it is 30, and continue until kidney failure or if it is tolerated, and always monitor for EGFR, potassium, BP, and at least initially. The consideration is genital mycotic infection, volume depletion, acute kidney risk, and hypoglycemia, which is, of course, it's very rare, but all these things has to be kept in mind. So we have various clinical trials starting from EMPARAG outcome, CANVAS, CREDENCE, DAPA-CKD, which have showed the benefits of SGLT2 inhibitors in patients with diabetic kidney disease. But the nutshell of all these trials is that CKD progression decreases by 40%, EGFR decline decreases by 25%, hospitalization of heart failure decreases by 35%, and cardiovascular death reduces by 20%. The practical point is that whenever you start them on SGLT2, you can have an initial dip of EGFR. Usually it is reversible. And whenever these patients are on diuretic, you should adjust the dose of diuretics. And always hold SGLT2 inhibitors during acute illness, surgery, contrast procedures, or whenever you are suspecting euglycemic ketoacidosis, especially in fasting. I think in Ramadan fasting, any spiritual fasting, we should be careful in using SGLT2 inhibitors because it can lead to dehydration and other things. So volume status, BP, and everything has to be monitored. Next molecule I will try to focus on diabetic kidney disease is finerenone, which is non-steroidal mineralocorticoid receptor antagonist. Its mechanism of action, it has anti-fibrotic effects where it blocks the mineralocorticoid receptor, reduces the collagen deposit and fibrosis, and we have seen this fibrosis very closely corresponds to albuminuria. And hemodynamically, it reduces intraglomerular pressures and albuminuria. It has its own anti-inflammatory effects and cardioprotective effects. So it can be used in those patients with diabetes with albuminuric diabetic kidney disease. And we should be careful with the potassium, and it is especially useful when your urine albumin creatinine ratio is more than 30 milligram per gram despite your RAS inhibition. And always monitor for your potassium because these drugs are known to cause hyperkalemia. Monitor your BP and volume. Avoid using this with other steroidal mineralocorticoid receptor antagonists, and always maintain your target potassium to less than 5.5. So finerenone has a very distinct effect compared to the steroidal mineralocorticoid receptor antagonists like spironolactone and eplerenone. So structural properties are different, and the hyperkalemia significantly increases with spironolactone compared to finerenone. Your kidney failure significantly, it has a protective data with your finerenone, and even other complications or breast-related side effects, which are very common in spironolactone, I have seen very less with Finrenone. So the indication, it has been used in those patients with CKD associated with type 2 diabetes, especially when there is a persistent proteinuria. These drugs has to be considered. So again, you have various trials. The efficacy summary, there's 18% decrease in the CKD progression, 14% decrease in cardiovascular events, 23% decrease in hospitalization, and 16% decrease in the cardiovascular death. The practical point, you initiate 10 milligram daily and titrate to 20 milligram if tolerated, and check for potassium and look for other drug interaction. And Finrenone combined with the SGLT2 inhibitor has shown a more additive benefit, and the urinary albumin creatinine reduction from baseline was greater than 30%, and which was seen even in 14 days when you combine both these drugs. So then you have a GLP-1 receptor agonist. So again, the metabolic action, you have various metabolic effects where it improves your glucose control, reduces weight, and lowers BP. It has a renoprotective effects by decreasing albuminuria, slows GFR decline. It has its anti-inflammatory effects, and it has a cardiovascular protection effect where it reduces your MACE, stroke, and heart failure. We have various clinical evidence, various trials where it have shown 24% decrease in the major kidney outcomes and 18% decrease in the cardiovascular events. The real advantage is that it has a weight loss effect, and BP reduction is also marginally seen, and albuminuria reduces by 30% at 104 weeks. Now, how do you use these drugs in your day-to-day clinical practice? First, any patients with diabetic kidney disease, you maximize your RAS blockade. You start with ACI ARB to the maximum tolerated dose, and you target on reduction of urinary albumin creatinine more than 30%. Always monitor for your BP, potassium, and still your albuminuria is more than 30, you can add SGLT2 inhibitors, and some say you add both things together. Still your albumin creatinine ratio is elevated, you add non-steroidal mineralocorticoid receptor Finrenone, and always still you feel weight benefit you require, or you require a cardiovascular benefit, you can add GLP-1 receptor antagonist. And avoid combining dual RAS blockade like AC and ARB. Avoid combining non-steroidal mineralocorticoid receptor with steroidal, and avoid combining DPP-4 with the GLP-1 receptor agonist. And your target should be to maintain your urine albumin creatinine ratio less than reduction. And when you combine many of these drugs, RAS, SGLT2, Finrenone, your benefit or anticipated event-free survival is much higher in terms of hospital of heart failure, all-cause death, kidney failure, or composite income. Of course, you have various other newer drugs like dual blockers and glucagon receptor antagonists. We have endothelin receptor antagonists, aldosterone synthase inhibitors, and we have guanylate cyclase signal inhibitor anti-inflammatory agents. And of course, glycemic control is very, very important. We cannot be banking only on drugs which prevent your diabetic kidney disease. Control your glycemia is very important. And my final take-home message would be annual EGFR and urinary albumin creatinine ratio testing enables early CKD detection. So you can have early intervention, can slow the progression. Residual risk persists despite RAS blockade and SGLT2, and mineralocorticoid receptor override drives inflammation fibrosis. Finrenone targets mineralocorticoid receptor overactivation, delivers cardiorenal protection, and clinical guidelines for the management of CKD in diabetes recommends a combination of drug therapies to optimally reduce risk at the early. Thank you.